Most of you know by now that I'm Eileen Sullivan. What you probably don't know is that I do have neuropathy, and that, would imagine with a 27-year journey with Waldenstrom's, I have had quite a few different treatments over time. And unfortunately, those early treatments weren't kind to the nerves. And so I do suffer with that. I am pain-free at this point, but numb. So I'm hoping to learn lots from this presentation about balance and neuropathy. And I think that fewer and fewer people these days will end up in my circumstance because we're not using those drugs much anymore. And even the nasty Velcade, you get it subcutaneously now. And so it doesn't do as much nerve damage. So we don't have to forget about that drug. For any of those of you in the UK who happen to have a consultant like Shirley at the University College London Hospital, you know that you're a very, very lucky patient. Just as in the United States, people travel to Mayo or Dana or the other centers where we have WM experts, in the UK there's only one place to go, and it's to see Dr. Dessau. And so, and especially if you have peripheral neuropathy, because she works so closely with a wonderful neurologist. She did a presentation a few years ago that many of us had a chance to see for the WM UK, but because of Zoom and because of the internet, we were able to watch it from wherever we were. So that's great. So Dr. Dessau actually started the Waldenstrom's program at the University of London. Yes? Right. Hospital. So they have a very dedicated Waldenstrom's program and consult with doctors all over the UK and probably all over Europe. So we look forward to learning and balancing. Thank you very much.
So morning, everyone. I'm really glad to be here and talk about one of my favorite topics. As I mentioned to people yesterday, WM and the IGM form a very talented team which can cause a lot of mischief in patients, and one of these is the neuropathies. I think I need my glasses, yeah. So, I'm going to talk, in this talk, I'm going to give a little bit of a background about peripheral neuropathy and its causes. We'll talk about the treatment of neuropathies. We'll talk about other strategies beyond actual treatment, such as anti-cancer therapies, etc. And then there's a few other things which I will mention, partly because they were on my remit. And I learned about a few things myself preparing for this talk. So starting off with neuropathy, the background and causes of neuropathies, I think it's really important to have really what I call a tour of the nervous system. Our nervous systems are very anatomical. It's a very anatomical system, and a neurologist can decipher the location of the problem, by and large, based on the presentation of the patient. Obviously, it's not as simple as that, because many different nerves and different parts of the brain and spinal cord do different jobs. But in effect, every bit of information to and from the body and therefore the environment that we live in must be coordinated and transmitted simultaneously and quickly. They go through the peripheral nerves and they come back through the peripheral nerves up to the brain, which is our supercomputer. And you can imagine the speeds needed are amazingly fast, because everything we do, there's all this crosstalk between nerves going on. So how does this work? Well, in effect, it is all to do with electricity, and on a kind of more, I suppose, molecular or even on a particular level, it is to do with the movement of ions, so charged atoms, potassium and sodium and others, which create a potential, which means that there's movement of electrons from one to the other. And so that is a very simplistic hematological explanation of neurological function. But in effect, there's the central nervous system, which comprises the brain and spinal cord, and then there's the peripheral nervous system, which is all the green stuff on this picture here. So if we dissect further into the nerve fibers, you can see here that, there are large and small fibers. I heard some people talk about small fiber neuropathy yesterday. So large fibers, both motor, the ones that produce movement and make muscles work, and sensory, the ones that receive stimuli and tell the brain what's happening, they're enclosed in many layers of myelin. And this is a picture of a nerve that's cut first, an actual full nerve bundle, which comprises a few what are called fascicles, which are actually little collections of nerve fibers. So when you then cut, you can see also that there's a blood supply there. Those red vessels are the arteries, the blue ones are the veins, and there's some in the middle as well of the nerve. This is really important because the nerve, in order to work, like any tissue, nerves need a good blood supply. And this is one of the reasons that certain therapies can cause nerve damage, because they can deliver toxic effects through the blood supply to the nerves. The other thing to remember about blood supply is that in a long nerve, like the sciatic nerve, which starts in the base of your spine, or around the L4, L5, it travels all the way down to the toes, okay? And it's the little bit, the end of the sciatic nerve has to get all it needs from the same sort of blood supply, but it's much more downstream. It's a bit like the Mississippi River. You know, it starts way up and goes down, down, down into the Gulf of Mexico. And a lot happens along the way, and the same happens with nerves. And this is one of the reasons why we have this length-dependent phenomenon that I'll talk about a little bit more. So that is really the anatomy of the nerve fiber. You've got the axon, which is the actual wire. Then you've got it surrounded by the insulation, which is called the myelin sheath, which again is not like a wire, you know, that we see in our, which we plug in, which is just like a plastic thing. These are cells called Schwann cells. They also have to metabolize. They carry out very important functions. And you can see on the next picture here that the way electricity is conducted through nerve fibers it's really accelerated by the presence of the myelin sheath. There's this hopping of potential or electricity in this way, shown by these arrows. So that's an myelinated fiber. In the lower picture on the left is a non-myelinated fiber. So there is movement, but it's different. And so what you can see is that when the myelin sheath isn't working very well, things are not going to move along as I showed you in the previous picture. It's going to be slow and sluggish, disturbed, and this is what happens. This is when we talk about demyelination. That is what's happening on a microscopic level. So in demyelinating neuropathy, the myelin is damaged, but the actual wire, the axon, at least to begin with, is preserved, but it isn't really able to do its job as it should. And in time, with some diseases, the protective function of the myelin sheath, when it's not there so much, that leads to damage of the nerve fiber itself. So in the end, you can get damage to the axon in demyelinating neuropathies. So the axon, which is the wire, what happens then? Well, obviously they're very specialized cells. Some are very long, some are very short. They receive and send signals to other cells. They're very fragile and thin, and they grow very, very slowly. In fact, for most of us, there's more or less not much growth of axons. In childhood, of course, things grow as the child gets taller and so forth, but there comes a time when there's very slow kind of replacement of damaged axons, if at all. So if there is recovery from a certain insult, it's something like 1 millimeter per month that it takes for an axon to regrow and to sort of replenish itself. So I think it was Jennifer who talked about the so-called autonomic nervous system yesterday. So the autonomic nervous system, another way I think about it is that it's sort of an autonomous nervous system. So it acts in the background, unbeknownst to us. It sort of carries out this sort of, the sympathetic nervous system works on this sort of fight and flight, and the rest and digest is the parasympathetic nervous system. You can also think about it as an automatic nervous system. So things happen which, so for example, if you know, in days gone by, if you suddenly, a big woolly mammoth came up to you, then you'd get the fight or flight response. And then, you know, that would release adrenaline into the system. It would get your cortisol levels up. You would just be ready to run, and your nervous system, everything would be ready. Your heart would beat faster. So the problem now, just as a slight aside, is that because we don't have woolly mammoths, but we have lots of little gremlins which bother us chronically all the time. So we have this constant, many of us anyway, fight or flight response, low grade, persistent, and this is something that causes stress, or is the result of stress, and can really weigh us down over time, and can make symptoms from the condition or the neuropathies worse. So again, worth noting, because when the autonomic system doesn't work very well, and that is a notable problem in many patients with amyloidosis, and that is when the light chains from the IgM, that component, they unfortunately have properties that cause them to deposit in tissues, sticky sort of tissues which are difficult to dissolve. They can cause a range of difficulties. So they can cause neuropathies by infiltrating actual peripheral nerves. They can also cause autonomic neuropathy, which can be very disabling, especially if it affects the blood pressure or the digestive system. So these are the kind of symptoms. I don't want to frighten you and send you off to sort of make a list and check these every day or whatever. But there are certain features that it's worth thinking, and I certainly, when I see a patient, certain things make me think about autonomic neuropathy. One is, if there is a neuropathy that's quite painful, I do always wonder about autonomic neuropathy, because it tends to cause a more painful neuropathy. The other thing is, if people are dizzy when they stand up, then this may be a feature of autonomic neuropathy. Sorry, the pain is to do with amyloid. I'll take that back. But it does make me think of, that's when we think of amyloid. The other symptoms of that amyloid can cause is dizziness when you stand up, because your blood pressure doesn't rise to keep up. It can cause a feeling of being full early on. It can also cause problems with diarrhea, because you're not able to, the nerve supply to the gut is affected. So if you develop these kinds of symptoms, funny sweating, mainly things like dizziness on standing, these sort of things, it's worth prompting your doctor if they don't think about it, especially if it's not related to medication. Obviously, if you're on blood pressure tablets, that needs to be dealt with. It's worth thinking about this autonomic problem, because although it's rare, it does need identifying and treatment in a very specific way. So I mention it mainly to highlight it. So in terms of neuropathies generally, in order to help your doctors to kind of pick up on things, especially in busy clinics where there's so many things going on, it's good to have a little checklist in this case, actually, about your neuropathy. When do the symptoms start? Do they come on gradually over days or weeks or months, or are they coming on very rapidly? Is there a quick change? Is there any timing to any medication or anti-cancer therapy that you've had? How does it affect you? Is it affecting your strength, your sensation, your balance? Do you get tremor? Do you get pain? Is it symmetrical, or is it only affecting one side of your body or one part of your, one limb or something like that? Is it worse on movement or bending or lifting, or, because at the end of the day, we all accumulate, for example, bad backs and so on. And of course, that can lead to squashing of nerves, which then supply the legs. And that can then be sometimes misinterpreted as a peripheral neuropathy, but actually it's a root problem. And so if you end up getting treatment for a nerve root problem with chemotherapy, that isn't a good thing, because you're not treating the underlying cause. We talked a little bit, I think temperature was mentioned yesterday in terms of conditions like cryoglobulinemia. You can get feelings of extreme cold or disordered sensation of temperature. Incidentally, neuropathies can also cause temperature sensation differences. So You can often go from zero to hero in terms of you know, a sort of symptom of going, and that's mainly because there's no, when you have a degree of neuropathy, you may not have the gray zones that leads from one to the next and eventually to a much more prominent symptom. It often goes from 0 to 100, it's like, and that can be very confusing and very disabling as well. And to be honest, there's not a great deal one can do about that kind of sensory disturbance other than perhaps dampen it down, which I'll talk about a bit later. Then the other thing is, you know, what helps to ease your symptoms? Is it certain positions? Is it rest? Is it medication? And also an assessment of how the symptoms are impacting your function. Because at the end of the day, we all want to function. And if you're impacted from functioning, then that's a problem. So those are features I think worth thinking about before you see a doctor, because it helps them to organize their thinking and perhaps assessment of your condition. So in the IgM setting, the key thing with neuropathy and IgM problems is the neuropathy, actually I'll backtrack, this is a slide about treatment. So I put treatment first because, I mean, I know Eileen has had very significant problems, and many have with certain treatments. I think there's a lot more awareness of this now. And so, for example, bortezomib is now given subcutaneously, or Velcade as it's called. And we found that actually tolerance is much better with subcutaneous treatment. And we actually sometimes treat patients who have neuropathies due to Waldenström's with that, because it can induce a quick response. And actually, if you want to treat the underlying disease, if you use something that works quickly, then that can be beneficial. Other drugs like vincristine, which was used in CHOP, should not really be used at all in Waldenström. So don't really let anyone give you vincristine. You can have CHOP without the O. O is Oncovin, that's the trade name for vincristine. So we literally avoid vincristine in WM patients if we need to use CHOP at all. And then other drugs like fludarabine in the past were certainly had some reputation for causing neuropathies, which are, again, not really used now. And drugs like thalidomide are not used in WM. So that's all I'm going to say about treatments causing neuropathies. I know some of you will have a legacy of that. And the main thing about that is obviously to stop the treatment or reduce the dose and move away from it. And the further away you are, things should improve, but they may level off. So then we move on to the WM, the IgM problem. Again, the key thing is, just because you have one and the other, it doesn't mean one is causing the other. And that is so crucial, because that means you will get treatment when it's needed and you will avoid treatment when it's not needed. So how do we work this out? Well, first of all, the history and the examination is really important, and that's where you do need to see a good neurologist. Now, when I say good neurologist, I'm not saying people are bad, but not many neurologists specialize in peripheral nerve disorders. They're quite a rare breed, actually. I'm very lucky to work with Professor Michael Lung, who that's what he does. And his nuanced understanding of the peripheral nerve diseases is really crucial. So he will, an examination, a history of how things came on, how they affect the patient, a careful examination, which can then be repeated subsequently to compare. These are all very important. You can then back that up with nerve conduction studies, or EMG, electromyography, which is a similar thing when you do the muscles as well. And it's worth noting a couple of things about nerve conduction studies. It is operator dependent, so you can get some electrophysiologists who are really excellent, and they can produce reproducible things that are trustworthy, if I may put it that way. But they also it's important to give them the information. So you don't just say, if you just say neuropathy, nerve conduction studies, well, it's hard for them to zero in, because they can do an endless number of things, which I believe it's quite painful to have these things shocked through you. So a good description of symptoms is important, but it's also notable that nerve conduction studies are only abnormal in large fiber neuropathies. So some people may have small fiber neuropathy and be very symptomatic, and they go and have nerve conduction studies, and they're told it's normal. And that's because small fiber neuropathies are not picked up on EMGs or nerve conduction studies. So the other thing to remember is that a one-off study gives you a snapshot, but if you want to see what's happening over time, then you need studies to be repeated. And the time scale is usually months, actually. You can't, doing it every week or month or whatever is going to be too soon. So a neurologist would have to take the decision about doing nerve conduction tests and interpreting them carefully. Sometimes they're quite hard to come by. There may be very long waiting lists, which is very difficult. But they can't be used standalone. Very rarely, you may need a nerve biopsy, and that is to look actually at the nerve tissue and see what is sitting in there, what's lurking, whether there are some inflammatory cells, whether there are lymphoplasmacytic cells, or amyloid, for example, or vasculitis, an inflammatory condition of blood vessels. And that is something we tend to do if there is still ambivalence, or we are not clear, there's ambiguity, I should say, about what might be the cause of the problem. If that happens, it's done usually under probably a local anesthetic, but it's often taken from the sural nerve, as shown in the picture. Sometimes other nerves are targeted, where perhaps there's more prominent symptoms. Occasionally, the disease is actually much more what we call proximal, so it's much nearer the spinal cord, and maybe in what's called the plexus in the armpits or the groins, or even in the cauda equina, which is where all the nerve roots come off the bottom of the spine. Now, clearly, the higher up you take a bit of nerve out, the greater the downstream damage. So that is something really not undertaken unless there's nothing to lose. In other words, if damage is irretrievable, then that may be the only way of confirming the information. So in coming down to IgM and neuropathy, there are kind of three broad groups in my view. One is the one caused by anti-MAG neuropathies. The other is an IgM-associated neuropathy with other antibodies. There are tons of them, to be honest, but the ones that kind of stand out are called ganglioside antibodies. And then you may have an IgM-associated neuropathy without any antibodies. And that is a bit more tricky because making that connection is difficult. And that's where specialist input comes in, because sometimes you have to make a kind of a value judgment and make a decision to treat. So although the antibody status may vary, the symptoms are often similar, but there may be overlap, but there are often also some subtle differences between the different conditions. In general, most people with IgM-related neuropathies, it's a slow process in general, especially with anti-MAG. It is often something that can be lived with for actually decades in many cases. And some people, not everyone needs treatment. Clearly, if someone is progressing, then one has to do something about it. So I must emphasize, just because you have a neuropathy and an IgM paraprotein, or even an anti-MAG, it doesn't mean the two are connected. So the role of MAG is, it's part of this myelin that I talked about. It helps to protect the nerve fiber. And when it's damaged, that can be a problem. And what happens with anti-MAG antibodies is they get in between the sheath, the layers of myelin, and separate them. And this is an electron microscope of a nerve biopsy, which literally shows this process, and that then leads to the poor conduction by the nerve. So how do we measure anti-MAG neuropathies, antibodies? Well, there are many methods, to be honest, which is a bit of a problem because people end up speaking different at cross purposes sometimes. The most common, perhaps accepted one is called the Bullman anti-MAG antibody ELISA method. And there are different levels of positivity. One is high, and that's above 70,000 Bullman theta units. In this bracket, it is most, and if there is a neuropathy, there's a greater chance that it will be a pathological contributor to the problem at this level. Lower levels of anti-MAG neuropathy, anti-MAG antibody levels are much less likely to actually be instrumental in causing the neuropathy. And this is borne out by studies that have been done on many patients, often in retrospect because of the nature of this condition. It's also notable that in some people, normal people who are otherwise healthy have a low level of anti-MAG antibodies as well. And that goes for other autoantibodies that we measure in many different conditions, like anti-nuclear antibody, etc. People often have a positivity, but that doesn't mean there's tissue damage. So that is something to note about anti-MAG. Just because it's positive, it doesn't mean it's significant. The other thing that in general we certainly do not do is measure the level in response to treatment. It's too blunt an instrument. We tend to measure the IgM paraprotein and obviously measure symptoms and see how those are going rather than say, oh, the anti-MAG has come down, because it doesn't correlate necessarily with response in terms of nerve fiber improvement or nerve symptoms. So who do we treat? The bottom line is if there is progressive disability, then immunosuppressive or immunomodulatory treatments are considered. The approach varies in different countries and in different clinical practices. What is for sure is that if there's less nerve damage, as I mentioned before, if the myelin is damaged, eventually the axon can get damaged because it's no longer protected. The less nerve damage there is, the better the outcomes. So I guess the best time to treat an anti-MAG neuropathy is early on when it's progressing, because you're going to get the best risk-benefit ratio, or the benefit-risk ratio. Now, it is very likely that we need to reduce the amount of antibody production as much as possible to get the best result, because these things are there sitting around making nuisances of themselves. The thing is, that would require probably getting a complete remission or response, and that is quite unusual in the setting of WM, with many of our therapies, as I'm sure you've heard from other talks. So that's one of the difficulties of anti-MAG neuropathy treatment. I mean, how heavy do we go with the treatment? Because you don't want to use a sledgehammer to crack a nut and have the patient who worse off than they were before. So that is not clearly laid out, but I'm pleased to say that therapies are becoming more, the BTK inhibitors, for example, are being used more. Most people will gain stability in their anti-MAG neuropathy rather than a dramatic improvement. So it's worth being aware of that as well. So there have been many treatments. Many of people with anti-MAG neuropathy receive intravenous immunoglobulin, which is a modulator of the immune system. So by having antibodies infused, your MAGs almost get diluted. They can't get a look in, so the IVIG can help. Now, this is something that can produce a short-term effect, but is not really beneficial in the longer term. So it shouldn't be used. But many people start with that because people think they have chronic inflammatory demyelinating polyneuropathy, which can also be demyelinating. Steroids have been used and can help in the short term again, and other treatments to suppress the underlying and clone disease, such as cyclophosphamide, have been used. Quite harsh, actually. And steroids, of course, long term, not good for anybody. Cyclophosphamide, alkylating agent, undesirable if it can be avoided. So, of course, rituximab is a very widely used drug. It targets the CD20. It should help to turn off the eventually, the production of the antibodies. So in general, that's the first line for patients with progressive anti-MAG neuropathy, which is established. The regimen, variable. We usually give weekly for 4 weeks, and then we allow a good 3 to 6 or even 9 or 12 months to make a true assessment of the response, because it does take time. If there is a response, then we may consider repeating that subsequently, and that sometimes maybe another 2 years down the line. If there's no response and things are still getting worse, then we may consider using other chemotherapy agents, not our preferred option, or perhaps BTK inhibitors. Now, BTK inhibitors can usually be prescribed in the setting of Waldenstrom's, but if it's a monoclonal gammopathy where the anti-MAG is present, that can provide a little bit of difficulty because the permission for BTK inhibitors is an underlying diagnosis of Waldenstrom's. So again, that can affect the way treatments are used. So it's a bit of a grey zone, the treatment of anti-MAG. I think that the take-home messages are that it's only treated when it's really progressive, but also a confirmed diagnosis. There needs to be sureness about the fact that the two things are connected, the neuropathy and the anti-MAG antibody. and then a careful assessment of response, not being too impatient, and to be honest, not being unrealistic about the kind of effects that you might get out of that treatment. The neuropathies without MAG, as I mentioned, they're a mixed group. So these are IgM-based patients or WM patients who don't have MAG antibodies but have neuropathies. They may have a mixture of clinical and neurophysiological findings, electrical studies in other words. They're very difficult to group together, and studies are really difficult because they're heterogeneous. So at the end of the day, it's a case-by-case basis, and you need ideally to see a specialist neurologist to make some plan about how to treat that. So again, the connection is important, and then the treatment, to be honest, it's a similar menu of treatments. We use the same kind of things. Rarely, lymphoplasmacytic lymphoma can actually infiltrate nerves, a bit like Bing Neal in the brain, but in nerves, in the nerve fibers. And so then, of course, you will use anti-lymphoma therapies. If there is a neuropathy associated with WM, so for example, you have an anti-MAG or infiltration or other sort of neuropathy, but the context is WM rather than MGUS, then you have all these different treatments available. And again, one needs to treat the underlying lymphoma as standard of care. Neuropathy itself is an indication for treatment if it's progressive. So your WM may be otherwise completely still and quiet and stable, but if your neuropathy is the feature that's causing the problem, if that's the end organ damage, then you do deserve therapy if it's progressive. Okay, so moving on to other aspects of neuropathy. So many of you who have neuropathy will recognize these kind of sensations, which can be very variable, come and go, sort of suddenly hit you out of the blue, be brought on by different stimuli. And everyone's description for their neuropathy is different, and that's fine. So sometimes there's a positive sensation like pain or tingling, or sometimes there's a negative sensation like numbness, you lose something. And of course then there's weakness as well and balance problems. So it's important to remember that nerve pain arises from anywhere in the nervous system, including the brain. So sometimes you can feel pain in your hands or feet, but it's due to a central assessment of pain. Same with the spinal cord. You can get pain felt quite far away from your central nervous system, but from CNS disease. So brain injuries, inadequate supply to nerves is another one. So some people develop, if you, for example, get pain in your legs when you've been up and about walking for a while, and you sit down and you get rest, you may have something called spinal spondylosis, or spinal, what's the word for it? Anyway, when you get the canal at the base of your spine is narrowed and it squashes the distal end of the spinal cord. Basically, what is happening, apart from perhaps squashing of nerves, is the blood supply to those nerves is cut off. So it's a bit like getting angina off your nervous system. So you walk around, you get pain, you sit down, you rest, it gets better. So if that happens and it's severe, then it's very difficult. I mean, the main thing is surgery, actually, to decompress those areas. But that needs imaging. So MRI scans, we do them quite regularly to try and delineate, especially if there's a history of back problems. Instead of simply thinking about the peripheral nerves, you sometimes have to look a bit more north and look at the nerve roots. I have to say alcohol is a trigger for nerve pain and damage. So if you do have neuropathy, I'm not saying don't drink because that would be miserable, but do moderate it because alcohol is a toxin. And if you have nerves that are fragile, it can make it worse. So less frequency, less amount is advisable. Then simple things like vitamin. You need to be replete with vitamins, B12, B1, for example. There are many other B vitamins which, I mean, you could take a multivitamin, but if you have deficiencies in specific vitamins which can be measured in the blood, they should be replaced because that gives your nerves the resources they need. And some medications can cause nerve pain, but usually that is something that would need, they'd be unusual medications. I think common ones, not so common to cause nerve pains per se. There are a number of other sort of or associated health conditions can cause nerve pain, which are much more common than WM, such as diabetes. So if you have diabetes, in addition to WM, sugar control is well, it's important anyway, but it's super important because, again, you're giving your nerves the scope to do their best under those circumstances. Shingles can cause nerve pain in distributions where the chickenpox virus is reactivated. You can get post-herpetic neuralgia. I mentioned strokes, trapped nerves, sciatica, all these things can cause pains. Then you can get all sorts of other pains, like fibromyalgia causing muscular pain, and other problems with facial nerves and syndromes, which can cause difficulties with pains. So again, the important thing is to delineate what's going on, because treating the cause is the best way to go. So you have to, how do you treat nerve pain? Well, broadly treat a cause if it's there and can be reversed. So surgery, injections for root compression, these sort of things. You then have to give pain-relieving medications. You try to have a setup that maintains functionality, and ultimately you want a decent quality of life. You don't want to be miserable, because nerve pain, like many pains, is not something you can just avoid and pretend is not there. It's horrible. It's just there non-stop. It can be there day and night. And frankly, if you can't sleep and if you're tired, that makes nerve pain worse. So there are different categories of painkillers. There are simple ones like aspirin or paracetamol, Tylenol, I think it's known here. You can use non-steroidal anti-inflammatory drugs sometimes. You can then move up a ladder towards stronger painkillers like codeine and oxycodone or morphine. No one likes those, but there are some circumstances where, judicious use of such agents is worth it, rather than being really miserable. But equally, it's the idea at the same time is to try and treat the underlying cause and make other improvements so that you're not necessarily bound to those treatments. The other group of drugs which are used very widely are what I'd like to think of as electrical modifiers. So they come under antidepressant categories, and they come under anti-seizure medication. So many of you will know these favorite drugs like amitriptyline, duloxetine, which are antidepressants, then others like gabapentin, pregabalin, carbamazepine. There is a whole range of them, and they, in my experience, with trial and error, they can be useful. And again, if it's worth persisting with them, none of them work like aspirin or paracetamol. They take weeks to develop a sort of, what they're trying to do is turn the volume down on the jangly nerves. And that takes time, because I talked about electrons. You can't just switch them off. Well, if you switch them off completely, you'll switch off as well. So it's got to be a gradual turning down a volume, and that's why these sort of drugs take a while. Of course, they're not side effect free, but then it's a way up between how bad the nerve pain is versus the use of these drugs. And even if you go on them, you don't have to be on them forever. You can tail them off. If they don't agree with you, you can stop them, try something else. So in my opinion, if nerve pain is a problem, as long as the underlying cause has been addressed and you've got treatment for that, it is worth having these kinds of discussions with your doctors so that you can get onto the right kind of medication. The other thing to say is that having this sort of pain relief will not make your neuropathy worse. It won't mask anything. It's not going to sort of mean that you allow things to get worse, and that is a different matter. So it's worth bearing that in mind. So there is this evidence-based neuropathic pain ladder, so I'm just putting it there because it was quite a nice picture, actually. But there is a science behind pain-relieving prescriptions. And to be honest, I'm not an expert. Neurologists often know about this, but there are pain management teams who are really expert in these matters. So you need to get to see the right people if you're having trouble with nerve pains. So moving on to other strategies. Well, there are many non-pharmacological strategies that are important. Some of them were touched upon yesterday by Jennifer, for example. And of course, you've had sessions with meditation and yoga and all these sort of things. So I think knowledge is important about things like the things we've talked about, so you have a better understanding of what's going on. Things like exercise, meditation, psychological treatments. There's a whole range out there. There's also an industry, so I warn you about that, with methods which have a lot of dollars attached to them. And so it's really important to know. I know if you have a problem, you can feel very desperate and you can go, I've got to try anything. But what you mustn't do is be parted with your well-earned cash if it's not going to be useful for you. So exercise. Well, we all know this. exercise is extremely helpful in so many ways. You get more strength and endurance. It physiologically improves you, and that means that you're more able to face whatever it is you have to face, even if it's further treatment at some stage. You get reduced fatigue. You get endorphins flushing all over the place, making you feel happy. It can help control weight. It can improve mood. So, we all know this. But how do we exercise? Well, now I'm no expert, so I have sought some help for this bit of the talk from a physiotherapist. So aerobic exercise is about increasing fitness. It's about reducing effort in day-to-day tasks, and it's about reducing fatigue. It's important to exercise at a low to moderate intensity. Go for a 5 to 6 out of 10 effort. So don't try and be a superhero, because that usually means you kind of give up early. It's more about being persistent and consistent. Don't exercise to exhaustion, because many of us are already exhausted. And you mustn't have muscle soreness and that sort of thing. Then you're doing too much. Pace yourself and consider the impact of exercise on your balance and your joints. Many of our joints are not what they used to be, so be kind to them and don't overdo it. So, there's huge numbers of guides about aerobic exercise, and I think the most difficult thing is actually get going and getting a kind of a system of movement. But even walking is excellent, and I know many of you probably do that. So that's one aspect of exercise. Then there's the muscle strengthening aspects, which can help reverse weakness from disuse of muscles. Often very important when you've been in hospital for a period of time, or unable to move around even at home. It also helps to just strengthen your core and helps you to support your skeleton and your movements and your joints. So again, depending on what's going on, you need to see a physiotherapist, get the advice and guidance. You can then do it yourself, but it won't be done without your input, I must say. So it is something you have to make a plan and stick to and try and measure how you're getting on. If you've got very weak muscles, build up slowly, because you don't want to overdo it. You don't want to cause injuries that set you back for a long time. Low to moderate weight training to start with, again, is important. Use it, be under the guidance of someone who knows what they're doing, and increase repetitions rather than weights. Okay, so don't sort of go from 5 kilos to 20 kilos. That's what my son sort of does. But it's about repetitions. Be consistent, but it's just getting those muscles back into action and moving them better. And as I said, you mustn't have muscle soreness longer than 48 hours. Otherwise, you're overdoing it. You're getting this lactic acidosis building up. Stretching. So stretching is something, again, we all know we should do, but probably don't do enough of. You can stretch passively. You can use orthotics, which I'll talk about. You can actually do active stretching. And there's things like soft tissue massage or even deep tissue massage. So it's good to try and work out where you have a problem, particularly, and maybe seek help for that. Identify the muscles, and aim to stretch daily, holding for 30 seconds each time. It takes a while for muscle fibers to kind of unclench, because that's their job. They just want to constrict all the time. So you've got to hold for 30 seconds, whichever muscle group you're doing. But it shouldn't be a painful stretch. And as the more you stretch, the less painful it gets, because those muscle fibers get more relaxed. Again, be careful of reduced feeling or changes in your joint position, because you can do more harm than good if you stretch in the wrong way. And I can't emphasize enough, you really should get a professional input at least once to kick you off, and then they can give you some exercises to follow. So balance training, I'm no expert at all, but the first thing I would say from my experience as a doctor is that it's important to know what the problem is with the balance. Balance is something that's directed from the brain, your eyes, you pick up, where you see where you are in space, but we all have what's called joint position sense, which is where we unconsciously know where our joints are, unless, of course, the nervous system goes wrong. So you need to understand, is it a joint position sense problem? Is it a middle ear problem causing the balance? Some people get vertigo, benign positional vertigo, which can be corrected by maneuvers. Is it something to do with cerebellum, which is the area that balances you? Is there Parkinson's disease developing in some way? Is it something to do with something in the spine that's affecting your ability to know where you are in space? So as I say, you must unravel why you're imbalanced, because that's the key thing to getting the right sort of strategy. So the aim is to really try and balance and be stable, become more stable by compensating your balance reaction. So if you're imbalanced, our muscles would kind of compensate instinctively. But if you have impaired nerve function, then that will happen less so. So if you have foot drop, for example, you don't have that normal way of correcting your balance. You sort of have to keep moving around because you don't have that muscle to help you. So be near something, be sensible, use an aid. I know that's a big step because people usually feel it's a failure, but it's better to do that to some extent until you're more confident, for example, or if you're going out and about or something, because a fall is the last thing you want, because you might break something or whatever. That's going to mean you'll be in a much worse position. So again, with these sort of things, it is a slow but steady approach. Do it gradually. There are all kinds of ways of balancing. Yoga is excellent for balance training. It's not for everyone, but you can have other sort of ways of doing this. The other thing that's really important if you have neuropathy is the use of ankle-foot orthoses. So these are supportive instruments, if you like, or inserts or contraptions, which can help to correct or limit things like foot drop. And I've seen in my own practice with Professor Lunn how super helpful these can be for patients, especially if you have foot drop and you don't have this ability to correct yourself. Having an orthotic to help do that can make a world of difference. The other thing to remember is there are tons of orthotics out there, so it's really important for you to get the right one. The idea is to reduce and redistribute the pressure under the foot and increase stability, help realignment. Many people develop drop feet, arches, if they have neuropathies, and that really puts everything out of alignment. So by correcting the arch deficiency, that can put you on the right track. There are many ankle-foot orthoses out on the market. Pretty certain with help you would find the one that is right for you. It shouldn't rub, it shouldn't give you pain, it needs adjustment sometimes, but it is possible to get the right ones. And if you do get the right ones, things wear out, so get them replaced. Don't let, Velcro, etc. It's got to be stable, comfortable, and if you have numbness, you've got to be careful with how you use them. Keep an eye, look at your feet to make sure there's no rubbing or loss of skin integrity. So miscellaneous things. So basically, acupuncture. I can actually speak from experience here. I have acupuncture quite frequently. I don't quite know how it works. There are these pressure points, and it's obviously it's a treatment that goes back thousands of years. It is, in my opinion, it's been very helpful. It is, for one thing, you are forced to lie down for like 40 minutes, and someone is fussing over you. So that's pretty therapeutic. The needles, I don't mind them, and the practitioner I have is he really kind of has an instinct of what's needed, and it's very stress relieving, and it can certainly reduce certain areas. They focus on different areas. So I mean, it's one of those things. Unless you try, you'll have no idea whether it'll work. But it has to be a consistent thing over several weeks, and you have to do it quite often. The only thing I would mention is the immune system. If it's low, these are needles. I mean, needles are used. Acupuncture is given with sterile needles by a proper practitioner, so I don't think there's any danger of that. But if you have low platelets, you could bruise more easily, and if you're on a BTK inhibitor, you could bruise or bleed. So these are obviously of practical significance. So just check with your healthcare team for advice, and it could help. Then the so-called transcutaneous electrical stimulation systems, there are different ones. They're used, to be honest, in our practice, we've never really prescribed them. Some people buy them over the counter and kind of just try them for pain. It works by delivering smaller impulses through electrodes on the surface of the skin, which is attached by adhesive pads. And they're meant to sort of almost distract some of the signals from going to and from the spinal cord and the brain by producing these aberrant or extra signals. It's non-invasive, and some people may well find it helpful. It's, I guess, more useful for more focal pain. It's difficult to have it all over the place. You need to be careful about allergy with the pads. And you may get some odd sensations like buzzing and tingling, and it's not for everyone by any means. I don't have a kind of list of how efficacious it is because it's used in many, many different settings. You just have to be aware if you're epileptic or have a pacemaker, you have to get someone to just okay that for you. So scrambler therapy is the first time I ever heard of it, actually, when I got this talk. I looked it up. I don't know if anyone's used it ever or heard of it. But, again, this is a form of treatment or therapy where they locate the site of the pain, they provide a set of leads in a certain area, and there's a gradual, they turn on the electricity, they turn up the juice, and gradually increase the intensity to the point where the patient can feel some sensations. And it seems to act almost as, it literally scrambles the nerve signals to your brain and seems to be able to improve pain relief. So I did ask my colleague, Professor Lunn, about scrambler therapy, and he's not aware of any convincing data to support this. So it's certainly not something that's widely used in our healthcare system. I think there is, I put a link there actually, that the Mayo Clinic has a page about it. So, and that's obviously a very reliable source. So if you're interested, you can go and look there. So, final thoughts. Can you wear stockings if you have neuropathies? These sort of, stockings, compression stockings. People often have swelling of their legs when they have reduced mobility or swelling from other reasons. You can, but you've got to be very careful because if you are numb in your feet, you just need to be aware that there's not too much pressure in one spot, etc. But again, you're not likely to need stockings unless you're an inpatient or if you take a long-haul flight, you may only do that. The better thing, I think, is probably to keep mobile. If you're an inpatient, then there's a limit to what you can do. So it's not an absolute no, but it has to be used with caution. It's good to have good foot care if you have neuropathy, especially numbness. So a visit to a podiatrist periodically is important to get rid of dry skin, which can then cut into other things, and So a simple thing, but worth doing, cutting nails properly, etc. You can also, in the setting, this is a Futura splint for carpal tunnel syndrome, which is when the tunnel in the wrist can squash the nerves, which gets worse usually when you sleep, because we often tend to do that. So ahead of, say, surgery or injections, wearing a Futura splint at night, which you can buy over the counter or get from a chemist or a pharmacist, can help to relieve that. If it's clearly not beneficial, then you may need something done about the carpal tunnel. And then I mentioned, I showed this leg, which with these changes, which could, if you have this sort of going on in the presence of neuropathy, and you have cold symptoms, it could be cryoglobulin. So it's also worth thinking about, because that needs special thought. And that is pretty much it. I'm very happy to take questions if anyone has any. Sure.
Well, I'll get this question in before I go check out. I had a deteriorating motor neuropathy in 2014, 2015, where, first I had trouble walking, and then a cane, and then a walker, and then they thought my posture was too bad in the walker. I had forearm crutches, and they didn't connect it to the Waldenstroms right away, and I went to see a whole series of specialists from about August till the following June. And finally they said, well, this is probably connected to the Waldenstroms, and I was treated with DRC, and the motor neuropathy went away. So my understanding is that sensory neuropathy is more common with Waldenstroms, and so my question is, what is the prevalence of motor neuropathy in Waldenstroms, and should Waldenstroms doctors be more aware that Waldenstroms can cause motor neuropathy?
Yeah, no, that's a great question. It's possible that you have a multifocal motor neuropathy, that may be the diagnosis, which is an antibody-mediated neuropathy. via so-called ganglioside antibodies. So it is a recognized phenomenon, and we have seen it in some WM patients. And in the context of WM, we would, you've clearly responded well. Look at you walking about. So yes, I think it's less common, but it does happen. And the so-called MMN, multifocal motor neuropathy, is recognized. So typically associated with certain antibodies. So they should be done as part of a general workup. The other cause for more motor problems is amyloidosis, which can cause problems with the supply to muscles. So I think the answer is absolutely yes. It's worth having what you've done, which is to get properly explored until the cause is found, because clearly you're doing well following the treatment, which is great.
Thank you.
Thank you, Dr. Sa. I'm being treated for 5 years on BTK inhibitors. I have a question. I wake up sometimes at night and have these cramps in my legs, in my calves, and they're quite painful. And then after a while, you get up and they go away. Does that have to do? What's happening there?
Yeah, so cramps are actually also very common. So muscle cramps, especially at night, where people have to jump out of bed and all the rest of it. And that may or may not be related to neuropathy. So many people without neuropathies get them as well. It is some form of imbalance with the electrolytes in the muscle. So there are strategies which you can use. So one of them is to use, to make sure you have, sometimes magnesium replacement supplements can help, although that's it's worth a try, nothing to lose for a couple of months. But otherwise, quinine is a medication which can help. It sort of modulates the way the muscles contract. Quinine is widely available. You just have to be a bit careful if you have kidney impairment, have a lower dose. You can also have, quinine is also found in tonic, so you can have lots of gin and tonic, maybe. More of the tonic.
So should I have tonic water near my bed in case it's painful,
Well, to be honest,
that doesn't work?
To be honest, it's not
like
enough. I'm joking a little bit. The amount of quinine in tonic is very small. So I think if you're having real problems, quinine sulfate is worth a try, because sometimes that makes all the difference.
Okay, thank you.
That's potassium more. Not that I'm aware of, but it's worth a try. They're very simple to get hold of.
I have a question about the use of steroids. I have back pain. That is, I'm using a patch, and I get steroids. And you said, don't take it so... And I've had x-rays and stuff, and they say it's not the bone problem. So I'm guessing right now it probably related to the disease, and that's a guess. But you said, don't take them for so long. What's long? I have the problem is thinning skin, and I don't have balance, and I'm wearing long sleeve shirts even in the summer. So what's long?
So steroids should only be taken for the minimum time possible in which they do the job. So there are some conditions like polymyalgia rheumatica, which can cause severe muscle aches and weakness and stiffness and so on. And in many cases, people get a big whopping dose, they then tail it off over a few months, they come off it, and that's the end of it. Okay. Some, however, and this goes for other conditions which are steroid responsive, you can't stop it fully, because when you do, there's a slight relapse, and the body notices that something's different. So in general, the shorter the better, but if you need to stay on it for longer, then the lowest dose possible is the best.
Yeah, I get a steroid shot now every 3 months.
Oh, like a depot thing.
Yeah, and I've taken they gave me the lower shot because of the balance in this this time. But the pain is
sounds
there.
Difficult actually. And the other thing is bone health. You've got to be very aware of that, as well as the skin.
First of all, I'd like to apologize. I came in late.
Okay.
And I'm a piece of work. I don't know if, I was diagnosed with having a problem with feeling numbness in my fingers. It felt like I was wearing rubber gloves all the time. And I don't count that as pain. Now it seems like it's getting worse, and like I'm wearing 2 pairs of gloves. I can't pick up anything else unless I'm looking at it. I also had some bones removed from my neck about 5 years ago because of stenosis in my neck. Getting a little bit of arthritis. Like I say, I'm a piece of work, but I figure I'm 3/4 of a century old and working on the 4th quarter. And the 4th quarter of a football game can be really exciting, but I'm shooting for overtime. Now, my question really is, and I also had, occasionally I would have carpal tunnel stuff, and I understand that there is a doctor in St. Louis, and I come here for the VA. The first time I was diagnosed with neuropathy was because of the VA and numbness from Agent Orange, but it seems to be getting worse. And I understand there's a doctor in St. Louis that specializes in neuropathy and is also affiliated with Waldenstorm's foundation. How difficult is it to get being part of a study locally, or maybe making an appointment with them?
So, well, in terms of the access to specific people, obviously, I wouldn't be able to advise. But in terms of studies, there is quite a problem with neuropathy studies because there aren't many actually. There are a few anti-MAG studies, which I think Dana-Farber is doing one. There are a couple in Europe looking at BTK inhibitors. So in terms of the availability, I'm sure the IWMF will be able to kind of direct you there. In other regards, I think I don't know the answer to that. I mean, I don't know if Eileen has a comment. It's more to do with the technicalities of referral patterns and practice.
Right, well,
But
there are clinical trials in the United States. They are all listed, as somebody mentioned yesterday, in clinicaltrials.gov. But the IWMF doesn't really specialize in finding neurologists. So I think you won't have much luck there, to be honest. I think you're going to have to work with colleagues in the St. Louis area and call the doctor's office specifically and start with a visit, a consult there, and see what they might be able to offer you.
Also, I'm on gabapentin, and I was wondering if increased dosage of gabapentin, and I'm going to be getting a new primary care doctor next month, and I need to talk to him about a whole bunch of stuff because I need to educate him about Waldenstorms. But I was wondering if increasing dosages of gabapentin might be something else to look at too.
yeah, for sure. I think everyone needs a different amount, and if you're on a very small dose, you can go up to 900 milligrams 3 times a day, for example. So you can upgrade the dose, but it needs to be done over quite a few weeks to see if that really helps you. But it's a trial and error thing, really.
Okay, thank you.
Hi, doctor.
Hi.
I have neuropathy. I'm a diabetic, so I had some very mild neuropathy before I started being treated for my Waldenstroms. I think it was the 3rd cycle they stopped the Velcade because, they check on it every time I'd go in, how my feet were in that, and they stopped it right away, and they said no more because that's one of the things. It definitely accelerated the neuropathy. I also have back issues that contribute to it and things like that. But one of the things that I found, the first ed forum I went to in 15, one of the guys gets up towards the end, because we were talking about cures or things for the cramps that you get, and I was getting some tremendous cramps. So he stands up and he said, "You're going to think I'm crazy, but the best thing for the cramps," he says, "it works for me, not for everybody, mustard. Probably the turmeric in it." And
Is that applied to the leg or?
no, I swallow it. You go to Chick-fil-A, McDonald's, you grab some mustard packs and stuff. I travel with them. I have them in my backpack. I got it by the side of the bed.
You just suck down the mustard?
You open it up, squeeze it down.
Goodness, other people swear by pickle juice. And
Pickle
I think,
juice.
what am I supposed to do? Put the pickle juice next to my bed and drink it at 3 in the morning?
That's the handy thing about the mustard packs. I keep them everywhere I go, right by the side of the bed. If I overextend myself during the day or something, working around the house, I know I'm going to get some leg cramps, I'll take 2-3 teaspoons of mustard right out of the jar, and more than likely I'm not going to get it. So it doesn't work for everybody, but it works for me, and I've passed this on to other people. Other people have tried it. It does work. So
Sounds
and
like distraction
the best
therapy,
part
yeah.
about it is,
Probably squeeze in one more question.
okay, the best part about it is, after you pop it in, you'll think of hot dogs.
I know. I was going to say, have a hot dog.
Yeah, one of your slides mentioned under treatment injections. What and where?
Oh, so it depends. So if you have, say, lower back problems or neck or whatever, it depends. So if it's a nerve root that's getting squashed, you can have injections around that root. If it's a facet joint, then you can have injections into the facet joint. And there are scans that help to distinguish between the two.
You have got a disc.
So that can be. But again, it's the attention to detail is what counts because everyone's back's different. So it's MRIs, a CT SPECT scan. These can pick up the drivers for pain, and then a targeted radiology-guided kind of injection can help.
That's what I'm doing now. Okay, thank you.
Do I have time for one more?
It is temp. I mean, it can last, if you're lucky, it can last a long time. Yes.
So neuropathy is my main thing that led me to Waldenstrom, and it struck me that it's not as easy to find out information about neuropathy as it is about Waldenstrom's because the foundation site for Waldenstrom is terrific. Do we have an association with the Peripheral Neuropathy Foundation? Would that be something to pursue in terms of association connections? I mean, there is one, it just doesn't seem to be nearly as helpful.
We'll put that in your evaluation,
Okay, yeah.
then that will get filtered through in
Yeah.
the post-forum conversation.
Okay. And then you mentioned that EMGs are operator dependent. How do you know if you got a good one or not?
Well, I'm lucky I work with my neurology colleague, and he goes through all these numbers, and he knows. It is hard to tell. I can't tell, but...
Is it a question of whether they did the right tests, the right nerve, the right distance?
It's all of the above.
Okay.
It's the amount of, potential they apply. It's how they did the thing, whether they did both sides to compare. It's a real specialization all by itself anyway, actually. So
Okay.
It's a good question. I can ask him what's the guide to finding a good electrophysiologist.
But the trick isn't in the interpretation of the results. It's
It is
really
that
in
as
the
well.
conducting
It is
the
that.
test.
It's conducting it, it's getting the readouts,
Yeah.
it's also interpreting it, and then correlating it to the clinical picture. That's actually the most important thing.
The core, okay.
Yeah. So it's quite a science and an art, actually.
Okay. All right. Thank you.
I've been treated with solar Rituxan for the last 13 years, or on and off. And now my oncologist says my peripheral neuropathy is not related to my Waldenstrom's, which is, what do I do now?
Did you get it for the neuropathy in the first place, the rituximab, or for the...
Yes, no, neuropathy was my presenting symptom. And the only one.
Yeah.
Well, of course, my IgM went up and everything, but
Yeah.
no.
So it depends. It depends to what extent your neuropathy is a problem now. It's like you probably need a sort of a check. We call it an MOT, which is what you do every year to your car. But it's like, take a snapshot. What's going on now? How bothersome is it? How has it changed over time? What are your levels, IgM levels like? It's sort of almost
So
like go
a
back to the,
review,
you
more or
know,
less, of
have
the
a full
current state
review.
of affairs.
Yeah.
And then see what to do next. See, that's my concern is what should I do? How should I deal with the problem? My IgM is going up, so I'm sure eventually I'll have to be retreated.
Sure. So
So-
I think if the IgM turns out to be a separate, a thing that's going up of its own accord, then you may need treatment for the WM by itself. But
It is
if
going up of its own accord.
then there'll be triggers for treatment for that. Yeah. If it's not related to the neuropathy, then you need strategies to help manage the neuropathy, which are parallel.
That's not happening. But
We can't thank you enough, Dr. Desai, and
You're very welcome.
for giving your time and coming all the way over.